Today we will discuss CNS infection. So we'll move on like first we have two cases. We'll discuss two cases of CNS infection. Then we'll move on to the broad variety of central nervous system infection, as in where the infection occurs, how it is presented. Then we'll briefly talk about meningitis. Then we'll briefly talk about encephalitis. Okay. So, in today's first case, we have a patient who is 18-year-old female who has a history of high-grade fever, high-grade intermittent fever for the last 12 days and vomiting for the last 5 days, along with headache, generalized fatigue and neck pain. So what do you think it can be? What is the differential diagnosis? I am not asking about the provisional diagnosis. I am asking about the differential diagnosis. Meningitis? Anything else? Differential diagnosis, remember. Don't give me a PD. Give me a DD. The more DD you can think of, the more better clinician you will be. Because your PD will be missed. Your provisional diagnosis can be missed. But if you have a 5 DD, any one of the 5 DDs will be the answer. So, do a differential diagnosis. What can happen? Generalized body ache, headache, high grade intermittent fever for the last 12 days. 18-year female. High grade fever, what can it be? Can it be dengue fever? Yes. Can it be? Can it be dengue fever? 12 দিনের জ্বর পেটি কি তো আমি লিখিনি I have not told you, maybe it is there. Is the symptom fitting with dengue fever or not? Which symptom is not fitting with dengue fever? Tell me. No, vomiting can happen in dengue. Neck pain. In dengue fever, where is the pain? Joint and retroorbital. Okay. So, anything else? Can it be malaria? Why not? You see the fever pattern? High grade, intermittent. Yes? Can it be maybe urinary tract infection? Can it be a UTI? A UTI can have vomiting. PID, if the patient has PID, the patient can have vomiting. Vomiting is a vague symptom. You cannot decide anything on vomiting. Neck pain. Again, neck pain is there. Okay. Okay. See, the basic investigation was done and WBC count was 12,200. Is it raised or is it normal? Raised? Okay. So, she was started on antibiotics. What antibiotics? Ceftriaxone. Okay. And the doctor also has given him acyclovir. Acyclovir is antiviral. See, on the third day of admission, she developed disorientation and fatigue and severe neck pain. Now, what is the differential diagnosis? Meningitis. Why? Because the neck pain is severe. It cannot be generalized now. So, there is some meningeal irritation. There are some meningeal signs are coming up. So, it is now probably a meningitis. Okay. So, we will see. Now, next, as because the patient had disorientation, which is a sign of meningitis, symptom of meningitis, and then she had a sign of meningitis, that is neck pain. The patient was opted for lumbar puncture for CSF study. So, the CSF was drawn and it was, I'll show you what was the result. So, this is just the basic vitals of the patient. Temperature was 99.8, pulse was 68, respiration rate was 18, blood pressure 120/80 and saturation 98. Anything which is abnormal here? No or yes? Which is abnormal? Temperature? Why? 99.8. ফিভার কাউন্ট করতে গেলে কত টেম্পারেচার লাগে? Yes. Okay. So it has not reached 100. Okay. And the rest of the parameters are normal. Had it been a respiratory infection, the saturation might have dropped down. I'm not telling 100% it will drop down. If the patient is old, COPD, chronic lung disease, then the saturation can drop down. So that you have to remember. So she was conscious and oriented, but was a little irritable. So that's also a meningeal irritation, meningeal sign. Now you see these are the investigation reports. So which things are abnormal? Don't go by the yellow marking, because all the abnormal things are not marked yellow. Some abnormal things are not marked only. Hemoglobin is normal. Total count increased. Platelet normal, increased. Okay. ESR slightly increased. Okay. Urea, creatinine, sodium, potassium. Anything abnormal? Sodium decreased. Okay. So 129. Okay. Then chloride, bicarb, and then LFT. So LFT was normal. And the patient was subjected for urine and blood culture, which did not grow anything. So it was no growth. So CSF tapping was done. CSF analysis showed it was slightly turbid. Glucose was 33. Is it normal? Glucose, CSF. CSF এর গ্লুকোজ কত থাকে? হ্যাঁ? What is the upper limit of the CSF glucose? More or less it is the around normal blood glucose level, or the lower limit of blood glucose level, around 60 to 70. So see, glucose is decreased or increased? Decreased. CSF protein 134, is it normal? Increased. Total count in the CSF is 320 cells. Is it normal? 320. CSF এ কত WBC থাকার কথা? 0 to 5. Okay. So is it increased, right? Next, see the distribution of the WBCs. Neutrophil is 10% and lymphocyte is 90%. So what does it signify? Lymphocytic leukocytosis, right? যদি নিউট্রোফিল বেশি থাকতো কি হতো? Neutrophilic leukocytosis. Now gram stain was done from CSF and occasional inflammatory cells was found. GeneXpert was done. What is GeneXpert? It is a cartridge based nucleic acid amplification technology. So it's a kind of a cartridge based PCR. Okay. So Mycobacterium tuberculosis was detected from CSF. Problem solved. Now you get the diagnosis, the patient was suffering from tubercular meningitis. Correct? Okay. So the antibiotics were changed, the antiviral was stopped, and the patient was started on anti-tuberculous treatment, ATT. Okay. So isoniazid, ethambutol, pyrazinamide, vitamin B6 and Visolone was started because the patient had cerebral symptoms. That's why steroid was given, and these all things were stopped. So should I isolate a tubercular meningitis patient? All of you know that TB should be isolated, right? Now, if a patient has tubercular meningitis, does it need airborne isolation? Does it need airborne isolation? Why? It cannot spread. So, from where did the TB come from in the CSF? The patient might have a primary somewhere else in the body. It can have. It can have a primary in lungs. You don't know. You have not done a chest X-ray. You have not done a sputum ZN stain. You don't know where is the primary. So, you must do a ZN stain of the sputum. If it is negative, then you can take out the patient from isolation. Okay. So, you have to always rule out the primary source of the tuberculosis. So, the nursing care was done and the patient was assisted. High protein intake, it is a very important thing. See, nutritional gaps were often missed. Nutritional gaps are very, very important for any infections because it is not only the drugs, not only the antibiotics, but also the body's own immune system that works. So, high protein diet is very, very essential. Now, what suggested a TB symptom in this is headache, fever and neck stiffness. So, that was the suggestive symptom for meningitis. Okay, the next case. This is a little bit different. This is not meningitis. Okay. So, don't confuse with the previous one. You see, again a 22-year-old female. She had come to the ER with a history of dog bite, where dorsal aspect of right wrist 7 days back. So, the patient had dog bite in a wrist. So, now she has come with a symptom of altered sensorium, irrelevant talks since the morning. So, what is it suggesting of? Rabies. Correct? Does rabies do encephalitis or meningitis? Encephalitis or encephalopathy? Do you know the difference between meningitis, encephalitis and encephalopathy? No? Okay. So, she had a fever for the past 4 days and had a difficulty in swallowing water and breathing. On examination, the Glasgow Coma scale was E3, V2 and M5. So, it was 10. Total score was 10. Meaning, she had a lack of spontaneous eye opening, but she was responding to painful stimulus and was localizing the pains. So, the verbal response was not good, it was incomprehensible, and but the patient surprisingly gave a history of taking post-exposure prophylaxis with anti-rabies, that is vaccine. The patient received 3 doses of post-exposure prophylaxis. Now, what might have gone wrong? Tell. Rabies is over, no? Tell. What might have gone wrong? Why did the patient develop rabies then? Somebody from the last bench, my favorite bench. Yes, green shirt. Yes. You don't know the color of his shirt, you've seen whether it is green or yellow. Tell me, what went wrong possibly? The patient had a bite of a dog. After that, she went to the doctor and the doctor has given 3 doses of post-exposure prophylaxis vaccine. Then why did the patient develop rabies? Sit and tell me. Think. Next. You know why I tell don't sit in the last bench? This is the reason. Next. Think. You don't know, I know you don't know, but you have to think. What is the mechanism of action of vaccines? We give antigens, right? So, the body, how much time will it take to develop antibody? At least 5 to 7 days, correct? So, if the patient had a category 3 bite, so what is the recommended prophylaxis? Is it only vaccine? No. It is also immunoglobulin. So you have to give immediate protection to the body. If you give vaccine, then you are delaying the protection because the body will take 5 to 7 days to generate the antibody. By that time, the rabies virus, if it is there, will multiply and go into the CNS. Right? So immediately what we have to give? Immunoglobulin. That was not given. See, no history. The poor child, she developed rabies. And you know, rabies is a death sentence. HIV is not a death sentence. You can live with HIV for long. No problem. But once you catch rabies, you are dead. Nothing to do. I have seen 2 cases rabies in my life. Both died. Even with the technology proof hospital, cannot save it. Patient will just go into coma. Similar thing happened with her. See, and then from the next day, CT scan was done and the CSF tapping was done because they were also thinking of some other bacterial or viral encephalitis. CSF glucose was normal. There were elevated markers and counts in the blood, but there was no culture from the blood or CSF. It was no growth. So she developed progressive hydrophobia and photophobia. MRI was done, and you see, this was the MRI, and you see this one is a lentiform fork sign. This is basically a pseudo lentiform sign, which is generally not seen in rabies. It is generally seen in other diseases like metabolic symptoms. So it was a mimicking, kind of a thing. But anyway, the MRI suggested of rabies only. And the biopsy sample was taken. So what is the antenatal diagnosis of rabies? Rabies ta kotha theke diagnosis hoy? Don't tell me brain biopsy. You cannot do a brain biopsy from a living patient for rabies, right? What do you see in brain biopsy? Nape of neck theke nebe. Ki nebe? Skin. Then vesicle. Anything else? Antigen. Where you will detect the antigen? Blood. Corneal smears? Yes. So what is the post-mortem diagnosis of rabies? Post-mortem? Negri body. Where will you find it? Brain. Okay, fine. So the patient had biopsy taken from the nape of the neck and which showed perivascular lymphocytic inflammatory changes, but she was admitted in ICU. Her condition deteriorated over the next 48 hours and she developed AKI, that is acute kidney injury. Ultimately, she died of some metabolic changes, metabolic problems, metabolic acidosis, and the patient could not be saved. So you see, petting dogs and feeding dogs is fine until unless you get a bite. Even if you don't get a bite, you might get a scratch. So don't neglect it. A scratch is also a category 2 wound if it is not bleeding. If it is bleeding, it comes category 3. Right? You remember the category 1, 2 and 3? Remember it for life, because you might have not, you might not be exposed yourself, but you will see other people. You will see somebody from your apartment coming to you saying, "Rasta jachchile meta kukure ek koreche ki korbo." You cannot tell I am a general surgeon. I don't know. That will not help you. Okay. So CNS infections. Now coming into what are the kind of infections? How many kinds of infections are there? So we'll just briefly go through. So there is meningitis. There is inflammation of the meninges. So meningitis can be acute, it can be chronic. We are talking about bacterial meningitis. So acute, there are so many bugs, and chronic, there are few bugs like tuberculosis, like Lyme disease, spirochetes and all. But acute, there are so many bugs depending on the age distribution of the patient. We'll come back to it. Then you have tetanus, and then you have viral meningitis. and myelitis. What is myelitis? Central nervous system में की पड़े? Brain and spinal cord. So what is myelitis? Meningitis, encephalitis. Encephalitis माने की brain matter. So inflammation of the brain matter is encephalitis. Inflammation of the meninges, leptomeninges is meningitis. So what is myelitis? Myelin cells. Not right, myelin cells. It's inflammation of the spinal cord. So that's why I was talking what else is in the CNS. So viral meningitis and myelitis is caused mostly by poliococcus and mumps. So you see, viral encephalitis is caused first by rabies, then HSV type 1 mostly, then arbovirus like JE and West Nile. We have a few incidents of Japanese encephalitis and Nipah and prions. Then we have parasitic infections like neurocysticercosis, amoebic infection, toxoplasmosis and fungal infection, which is cryptococcal meningitis. That is very important. So these are the causes that are written in the book. Now coming to the meningitis. You see, the leptomeninges is consisted of arachnoid and pia mater. It is here. You have read it in anatomy. So this is the bone of the skull. Then you have epidural space, then dura mater, then arachnoid mater, subdural space, arachnoid mater, then subarachnoid space, and then pia mater, then the brain. So this is how it is. So acute meningitis and chronic meningitis, why it is different? Because you see the prognosis varies. In acute meningitis, the patient will succumb to the infection, the patient will go on to intensive support or ventilatory support may be needed, or the patient might need a very rapid or some multi antibiotic therapy, because the patient might progress in a very short time. In 1 to 2 days, the patient might land up in a full blown infective etiology and the Glasgow Coma Scale may drop down. So that's why you should treat acute meningitis aggressively. And chronic meningitis, mostly the symptoms will be progressing over few weeks. So over 4 or 5 weeks, the patient might progress into the symptoms. Now, if we consider acute meningitis, then what can we see? Mostly it will be elevated polymorphonuclear cells, that is the neutrophils. That's what I was talking. In the first case, if you remember, there was a lymphocytic predominance. It was not a neutrophilic predominance. Okay. So we will see what is the comparison between a bacterial, a viral and a tubercular meningitis. I have a chart. It is there in the book also. So overall, you see, Streptococcus pneumoniae is the commonest bug for the pyogenic meningitis. Other infections can be caused by meningococcus, group B strep, listeria and other gram-negative like E. coli and Klebsiella. In the viral meningitis, if you consider, then enterovirus, herpes virus and Japanese encephalitis, West Nile, these viruses can be caused. Chronic meningitis, again the meningitis which is associated for more than 4 weeks, and the white blood cells are raised, but it is not like acute, so it will be a little less than acute. Aseptic meningitis is that which the etiology cannot be identified, so we term it as aseptic meningitis. So meningitis is there, but you cannot determine which organism or why it is happening, so we call it aseptic. Clinical manifestation for acute meningitis is high grade fever, vomiting, headache and neck rigidity, and there will be also 2 specific signs. One is a Kernig signs and one is Brudzinski sign. Okay. So this Brudzinski sign and Kernig sign you can see in the book. It is, this is a First one is the Kernig sign, that is when you pull up a patient's leg, it is flexed 90 degree. Okay. So, you cannot put the leg straight, it is difficult. So, you cannot put the leg straight because this is the sign of the meningeal irritation that I was talking about. The patient will have difficulty in flexing the neck, and again the patient, if you flex the leg at 90 degree, you cannot put it back straight. Okay. So, this is the Kernig sign. And next is the Brudzinski sign, which tells you that whenever the patient is lying flat and when you are trying to lift up the patient by the neck, as it is stiff by the neck, if you lift it up, automatically the involuntary hip and knee flexion will occur. So, you lift this up, the knees and the legs will be involuntarily flexed. So, these two signs are very much indicative of a pyogenic acute meningitis. You can see this in the patients, if you try, you can see this. This is very common. Okay. Now, encephalitis, as I was telling, it is the inflammation of the brain parenchyma. A few difference from the meningitis, if you see, altered consciousness, behavioral changes, seizures. It was not there in meningitis. Seizures can happen and some focal neurological deficits can happen because it is the brain that we are talking about. It is not the meninges. Okay. So, if the brain is involved, then some focal neurological deficits like a paresis of a limb or numbness of a limb can occur in encephalitis. Encephalopathy, I asked, what is encephalopathy? Any diffuse disease of the brain that alters the brain function. It might not be an infection always. Okay. So, we call it, suppose, a metabolic encephalopathy, means it is a diffuse disease of the brain, something which is affecting the brain, something which is affecting the function of the brain. But metabolic encephalopathy is not an infection. Okay. So, encephalopathy always does not mean infection. It can be infectious, it may be non-infectious also. See, in infectious, you can have some slow viral diseases, prions and cerebral malaria that can occur. Now, brain abscess, which is not so common, but it can occur. If you see, the streptococci and some anaerobes like Bacteroides, like this, and Fusobacterium, E. coli, Klebsiella, these bacteria can give rise to focal CNS lesions like brain abscess. For brain abscess, it is the CT scan is the primary modality of the diagnosis. Otherwise, you cannot diagnose whether it is a encephalitis or a brain abscess. Yeah, acute bacterial meningitis, the causes according to the age. This might be asked in the exams. For the neonates, the first cause is, the most commonest cause is Streptococcus agalacti, followed by E. coli, Klebsiella, that is the fermented GNBs, and Listeria. So, these four are the commonest causes. For elderly more than 60 years, the GNBs are not the common cause. It is mostly done by Streptococcus agalacti and Listeria. Okay. Symptoms I have already told. Routes of transmission, mostly it is hematogenous, that is the focus might be somewhere else in the other parts of the body, and that organism will gain access to the meninges through the choroid plexus. So, that is how it enters the system, the CNS, and this is the hematogenous spread. And if we talk about other spreads, it can spread directly through of middle ear and then some sinuses. It can happen, otitis media and sinusitis, post-sinusitis, post-otitis media, the patient might develop a meningitis. And obviously, if the patient is having any CNS surgeries like shunting, like road traffic accident, like any burr surgery, then post-operative complication, the patient might have infection directly instilled inside the brain or the CSF that may give to a acute meningitis. So, these are the most common causes or transmission routes for the disease. Now, coming to the lab diagnosis for any kind of meningitis, first of all you have to collect CSF. Next sample you can collect is blood. In blood culture it may not be positive, but it might be positive if the patient is a secondary meningitis. Okay, so you might find something in the primary bloodstream also. So, you have to tap the CSF by lumbar puncture. Lumbar puncture is a very aseptic procedure which is done in the ward or ICU itself. There is a fixed position as to the patient might sit, the patient might lie and bend. So, you will learn in internship again, in medicine also you will learn. And you have to collect CSF. There is a needle called LP needle, lumbar puncture needle. And then you have to collect CSF and put it into 3 containers. Okay. Now, the reason is, you see, one container will go for cell count. That is done by which department? Cell count, biochemistry, pathology, microbiology. Pathology? Confidently say yes. Pathology will do a cell count. One sample will go for biochemical analysis, protein, sugar, all these things, which will go to biochemistry. And one sample will be going for culture and gram stain, ZN stain, India ink, etc. etc. So, 3 departments. If you give one tube, the 3 departments will fight amongst each other. Micro people will come and tell, you cannot open my vial. If you open my vial, I will not take the sample. If you open a sterile vial, it is unsterile. This happens. Sometimes it happened, I have seen, the CSF was only one sample was given. Okay. And the pathology people took it. The microbiology did not know that the pathologist has already taken the sample because it came in the night. So, pathology has taken the sample and given a cell count and all those things. So, they have used a pipette. It was not sterile. Pathology does not use a sterile pipette tips always, no. They do not need a sterility. Do they need a sterility? No. So, they have used a clean pipette tip and they have kept the sample back in the fridge. So, next day microbiology has cultured it in the agar plate. Full E. coli, Klebsiella, Pseudomonas, everything has grown. Okay. The cell count was 2. Now, I got confused as into what happened. Because if the cell count is 2, your protein sugar level is normal, then you cannot grow so many organisms. And if you grow E. coli, Klebsiella and CSF, the patient is already visiting God. No? So, it was a contamination. Later we found out that the sample was already opened and somebody took the sample with a non-sterile pipette. So, it was a contaminated sample. And there was again another fault. If you have to do a microbiology testing, you cannot put the CSF in the fridge. Why? Haemophilus influenzae is thermosensitive, cryosensitive. So, it will die. So, for microbiological samples, CSF, you keep it in the incubator. That is recommended. If you do not have an incubator, you keep it in the room temperature, but do not freeze it. Do not freeze it. The rest of the samples for molecular testing, you can put it in the fridge, no problem. Even if the Haemophilus dies, the PCR will take up the DNA, not a problem. But if it dies, then it cannot grow in culture. So, you do not have to refrigerate a CSF for microbiology. You cannot, that is a rejection criteria. Okay. So, this is the procedure, how the patient is lying on the sideways and the back is flexed, and then you have to take the CSF by the lumbar puncture needle. So, this is the blood culture. For suspected meningococcal meningitis, sometimes a nasopharyngeal swab also is used for taking the sample. And again, for meningitis, you have to have a transport media. So, Stewart media is used. Now, this was the chart that I was talking about. You will find it in the book. See, only 3-4 things you see. First, concentrate on the total leukocyte count. In the normal, it is 0 to 5. Remember this. Okay. So, anything above 5, it is abnormal. So, you see in the pyogenic meningitis, that is the bacterial meningitis, how much is the count? 100 to 10,000. In the tubercular meningitis, it is increased, it is above 10, but it will be below 500 mostly. In the viral meningitis also it is increased, but it is again below 500. So, pyogenic meningitis gives to the highest leukocyte count in the CSF. That is the take home message. Then concentrate on the predominant cell type. If you see, the normal individual will have a certain occasional lymphocytes. Okay. Now, if you see the pyogenic meningitis, neutrophilic leukocytosis, that was I was talking about. So, neutrophils will be high in the bacterial meningitis. If you come to TB, then it will be lymphocyte. So, lymphocyte will be high, and again in viral also lymphocytes will be high. So, only in bacterial meningitis you will see a large number of or a larger proportion of neutrophils in the CSF. Then come to the glucose. Glucose, as I told, the upper limit of the glucose in the CSF is 70. So, anything above 70 and anything less than 40 is abnormal. 40 to 70 is the range. So, I remember it like this: bacteria is here and also mycobacteria is a bacteria, right. So, you remember bacteria eats sugar, which is actually a true phenomenon, right. So, they eat sugar. So, if they eat sugar, then the sugar will be less or high? Less. See, in the TB also it is less, in the pyogenic also it is less, correct. Now, if you go to virus, it is normal because virus they do not eat sugar, that is all. Now, I remember like this: pyogenic meningitis is a bacteria, tuberculosis is also a bacteria. So, any bacteria that is eating sugar will be multiplying, and when it be multiplying, the proteins will be high, correct, because bacteria is protein. So, the protein will be raised. So, this is above 45 and this is above 100. So, tubercular meningitis, the proteins will be higher, bacterial meningitis, the protein will be high, okay. And viral meningitis, it is either normal or slightly elevated. So, if you remember like this, you will not forget. This is very important because any CSF you have to read like this. Now, microscopy, I will not go into the details. This you know, which is GNB, which is GPC, which is GNCB, which is GPB. Okay. One thing is that Listeria monocytogenes, it is sometimes it is a confusion between a diphtheroid and a Listeria because it looks like a diphtheroid. So, it is a GPB, gram positive short bacilli, which is often misidentified and disregarded as diphtheroid. Okay. So, usually we do a heaped smear, because CSF is a very sterile sample, it usually does not contain so many cells. So, what we do is, in a slide we put on one loop of smear and then again we put another loop and then again we put another loop, like 3 to 4 loops we put and make it a circle and then we put it for the gram stain. You can centrifuge the samples and you can also do a direct antigen detection like latex agglutination test. Okay. So, direct antigen detection is available for pneumococcus, streptococcus, agalacti, meningococcus, influenza and E. coli. It is available. For culture, it is very important that you put all the CSF into enriched media, mandatory. What enriched media? Blood agar and then chocolate agar, mandatory you have to put. And also you have to put this for a enriching media. Enriching media means it is not a particular category of media, but it is recommended that you put into either a Bactec vial, which will, because you see Bactec vials have certain components which amplifies the organism very fast. So, ideally it should be put into a pediatric bacterial vial because your CSF sample is very low. If you put into a normal adult blood culture bottle, it will be dilute, very much diluted. So, you put into a pediatric blood culture bottle, okay. Or otherwise, you can also do a culture in the BHI media, that is brain heart infusion broth. So, that is also a liquid culture media. And for the culture plates, it is preferably that we put the culture plate into a 5% CO2, that is candle jar. You know what is a candle jar? Yes, for Haemophilus it is required. So, individual organisms, you just see the pictures. Streptococcus pneumoniae, it will give alpha lysis or a carom coil appearance in blood agar. Neisseria will give a non-hemolytic colony. If you do a gram stain, you can see a gram negative diplococci. Haemophilus influenzae, in the blood agar, it shows satellitism with Staph aureus. Now, my question is, what is satellitism? Haemophilus is covered, bacteriology, over long back. So, you have deleted Haemophilus from the brain also. Satellitism kake bole? It comes in the question, very important. আমি শুনতে পাই না, প্রথম দিনই বলেছি, কম শুনি। বলো, what is satellitism? Which factor is there in the chocolate agar and which factor is there in the blood agar? Factor 5 আর 10 দুটোই chocolate agar দুটো থাকছে, আর blood agar কোনটা থাকে? Factor 10. Agreed? Chocolate agar contains factor 5 and 10. Do you know what I am talking about? বুঝতে পারছো তো? চকলেট আগারে কি ফ্যাক্টর থাকে? 5 and 10. Why? Why it is not there in blood agar? ওকে বলতে দাও না তুমি তো পাস করবে, ওকে তো পাস করতে হবে। Tell. Chocolate agar contains 5 and 10. It is written there. মানে বোর্ড দেখো বলতে পারছেন না মনে হচ্ছে, হ্যাঁ? It is not written there. That's why you could not see. Chocolate agar contains 5 and 10. তাই তো? ব্লাড আগারে কি থাকে? কোন ফ্যাক্টরটা থাকে? না, আমি বলছি ব্লাড আগারে কোন ফ্যাক্টরটা থাকে? 5 না 10? 10. Why not 5? What is chocolate agar? What is the component of chocolate agar? How do you make it? 45 degrees centigrade. I have not asked you. No, first benches are exempted from answering questions. That's why you are first bench. I'm asking the last bench, always my favorite bench. I have told, no. So this last bench cannot answer. I'll ask this side. Yes. How do you make a chocolate agar? Basic first week of microbiology. Chocolate agar মধ্যে কি দেওয়া হয়? চকলেট, ডেয়ারি মিল্ক, হ্যাঁ কি মোল্টেন আগারের মধ্যে চকলেট দিয়ে দেবো। So you heat the blood. So what happens if you heat the blood? Blood contains what? RBC. Lysis of RBC. So lysis of RBC. The simple 3-word answer. Lysis of RBC liberates factor 5 from the RBCs. Okay. Now that factor 5 is essential for Haemophilus. Agreed? So whenever a RBC is hemolyzed, factor 5 is liberated. So in a blood agar there is no factor 5. But if you put a Staph aureus will hemolyze, beta lysis, RBCs will be hemolyzed. So factor 5 will be liberated, which will be taken up by Haemophilus. So if you do a Staph aureus in streak on a blood agar, and if you streak a Haemophilus near to the Staph aureus, The colonies which are near to the Staph aureus, the Haemophilus colonies, they will grow big because they are getting factor 5 from the hemolyzed RBCs near to the Staph aureus. Understood? Kara bojoni hat tolo because জীবনে এটা আর কেউ বুঝাবে না. So everybody has understood. I'll ask in the exam. Okay? Understood? This is called satellitism. So the more you go away from the streak of the Staph aureus, the colonies get smaller. The colonies get smaller. The Haemophilus colonies get smaller. And the more you get closer to the Staph aureus, you see here, this is a Staph aureus streak and this is the Haemophilus which is lawn culture. So if you see the Haemophilus colonies are bigger, you see bigger colonies here, and the more you get away, it becomes smaller because there is no factor 5 here, but there is factor 5 here because RBC lysis is being done. Okay. Streptococcus agalacti produces a beta lysis, E. coli no lysis, Listeria it shows a tumbling motility, but it is non-motile at 37 degree. That's why it is called differential motility. Molecular methods can be implemented. You can do a CNS panel for biofire. You can do a open platform PCR, and treatment is mostly either you give cephalosporins or you add gentamicin with the ampicillin for the neonates, and of course you can have a dexamethasone to treat the increased intracranial tension. Now encephalitis, that is a viral encephalitis, I'll just brush a few things. Herpes simplex virus is the commonest one, mostly HSV1, followed by CMV, HHV, varicella and Epstein-Barr, but mostly it is herpes simplex. In the arbovirus family, Japanese encephalitis is the most common cause of the encephalitis in India, followed by rabies. Nipah and Hendra are very rare. In encephalopathy, I told prion diseases and few cases of measles and rubella can cause encephalopathy. Now HSV encephalitis, as I was telling, it is a common cause because whenever you see a CSF picture suggesting of a viral meningitis or a viral like infection, then you give a PCR for HSV type 1 and type 2. Sometimes I have seen that it comes positive. It comes positive for HSV1. So HSV1 is most common than HSV2, and it is the most, HSV itself, it is the most common cause of the acute viral encephalitis. Laboratory diagnosis, I told you have to detect the viral DNA by PCR, and treatment is IV acyclovir. Okay, I think this is my last slide. Yes. So today you go home and read about satellitism first. Second, you read about which organism? Tuberculosis. Third, you read about rabies. Okay. Fourth, you read about CSF sample collection, transport and lab diagnosis of meningitis.